Take it away.
Thank you very much. First, while we meet today on a virtual platform, I wish to acknowledge the land where I am is the traditional territory of many nations, including the Mississaugas of the Credit, the Ishnabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. As a settler myself, I am committed to working in solidarity with Indigenous communities that are working against colonialism and towards reconciliation. Thank you very much to Shinur Koram and Laura Paciolo for their superb organizing of this virtual symposium. Looking at the lineup of speakers, I am in awe of all of the brilliant work that people will be presenting. Kudos to the organizers for bringing this all together. Thank you also for Brittany for making sure that the tech works, right? That's always something that we're super nervous about. It is an honor to be invited to deliver remarks for all of you today. I'd like to start my talk by openly recognizing that COVID-19 has led to a crisis in social reproduction. To give you an idea of how, let's start with a personal. Let me set the stage of where I am right now. I am a mom of 2 kids, and they're pictured on the slide. My 1-year-old daughter, Georgina, is now in daycare, where she is being cared for by her wonderful teachers, Andrea, Jenny, and Noreen. My 4-year-old daughter, Winifred, is now in school under the tutelage of Miss Plotnick and Miss Silva. I am delivering this talk with my door shut, hoping that when my children return home, they will not disturb us. No guarantees, though. While I appreciate that schools are open again because it was impossible to work when we were all self-isolating, I am aware that COVID rates are rising. This means that I am perpetually worried that our decision, me and my husband's, to send the kids back to daycare and to school was the wrong one. I worry too about Andrea, Jenny, Noreen, Miss Plotnick, Miss Silva, and the other teachers and early childhood educators who put themselves on the line every day to care for our children. I also worry too for friends who have been socially isolating by themselves since March, but who nevertheless still have caring responsibilities. My worries about care extend beyond Canadian borders. Next to me is my phone, where I am in several group chats. One of the groups that I am in has 40 members of my family living across the United States, Canada, and the Philippines. I am getting constant updates from this group chat because my Lola Raquel, my grandmother's sister, recently passed away. We are now engaged in transnational mourning rituals. I wish I could say that I am new to this, but COVID has hit my family and my community quite profoundly. Since March, I've taken part in no less than 4 virtual wakes, all in honor of lives lost either because of COVID or because COVID curtailed people's access to care. I have nurses, doctors, and other healthcare workers in my family, and I am aware of the risks that they face. I know that these risks are compounded by race and by class, showing, for example, that even though Filipino nurses make up 3% of all nurses in the United States, they constitute up to 40% of all COVID positive transmissions. And yes, these healthcare workers include some of my family members who have gotten COVID, including their children. I am grateful that they have recovered. Why am I starting with all of this information? To be clear, despite being a millennial prone to oversharing, I am not giving all of this information just because I will be talking about the disproportionate effects of COVID on racialized migrant communities. I want to highlight that many of the theories, policies, and narratives that I will share are ones that I, like many of you, understand so intimately. Let us begin by thinking through statements of solidarity and encouragement that have been shared incessantly since the beginning of the pandemic. All of these are variations of "we're all in this together." I understand why it is important to foster a sense of community solidarity to encourage people to fight against the common enemy of COVID. These sentiments also help mitigate people's sense of social isolation. Reading these, though, what these sentiments make me think about are the vast social inequities that have been amplified during COVID. To be clear, COVID has created and magnified inequities that are already widespread. Institutions that are already beset with sexism, racism, ableism, and classism, such as workplaces, schools, and even the family unit, have revealed just how unequal they truly are during COVID. Austerity measures passed by successive neoliberal governments have steadily chipped away at existing protections, such that when COVID hit, the safety valve that might have protected communities was eroded, leading to even more cases of COVID infections and deaths. The starkest example of this can be found in long-term care facilities, which I will talk about more later. Suffice it to say for now, though, that as Pat Armstrong's research reveals, the privatization of care has led to a rise in for-profit long-term care homes. Such privatization has decreased the quality of care received by patients and have eroded labor protections for healthcare workers. Thus, during the pandemic, long-term care homes were virtually defenseless. It is no wonder then that in the wake of privatization and increased cutbacks in funding, between 82% to 90% of all COVID-related deaths in Canada occur in long-term care homes. It is no wonder that research has revealed that out of all healthcare personnel, personal support workers, and healthcare aides working in long-term care homes are the most likely to get COVID. The vast majority of PSWs and healthcare workers are middle-aged, racialized immigrant women, again showing how race, class, and gender are relevant. In essence, you cannot solely blame COVID for these deaths. Rather, austerity measures that cut funding for long-term care and that eroded protections for patients and workers led to these deaths. Let's think about schools. Schools in Canada have opened using various learning options, such as in-face learning, remote learning, or a blend of both. Yet, despite the best efforts of school boards, schools have to adapt to the reality that either a student, teacher, or staff member will get COVID, forcing entire classes or even entire schools to self-quarantine. Yesterday, the Toronto Catholic District School Board announced that one of their staff members, a 67-year-old woman who returned to work in the school, died of COVID. Although we could say that, of course, COVID transmissions are inevitable, neoliberal governments have cut back funding for schools so much that class sizes have increased, there are constant staff shortages, and school resources have been vastly reduced. Had these measures not been implemented, and if schools have decreased student-teacher ratios and more resources to renovating classrooms, to increase ventilation, and to buying more PPEs, will there have been as many COVID transmissions? It isn't lost on me that the industries that are dominated by women and racialized immigrant workers are the ones that face the least protections when it comes to COVID. The majority of care providers in long-term care facilities are women, as are the majority of teachers. Meat packing plants and farms, which have had COVID outbreaks, are likewise predominantly staffed by racialized migrant workers. Ultimately, I argue that persisting structures of necropolitics and necrocapitalism have revealed that some lives are worth more than others during COVID. Specifically, I argue that in Canada, racialized working-class migrant communities have been hit hardest by COVID, yet corporate and government discourses of migrants as essential workers and as heroes deliberately obscure migrant workers' vulnerability. I also argue that the workings of necropolitics and necrocapitalism during COVID enable the conditional inclusion of some migrant workers, provided that these migrant workers are willing to sacrifice their lives to save white middle-class Canadians and Canadian businesses. What is necropolitics? As a concept first defined by Cameroonian political philosopher Achille Mbembe, necropolitics highlights how states exercise sovereignty by being able to determine who may live and who must die. Taking his cue from Mbembe, necrocapitalism, as discussed by American political geographer James Tyner, shows how, quote, there is a fundamental contradiction between the demands of capitalism in the pursuit of profit and the requirements to sustain life itself, end quote. In writing about a new political economy of premature death, Tyner believes that capitalist economies only value those bodies that are productive, i.e. those that are in a position to generate wealth, and are responsible, i.e. those that can participate fully in the market. Those bodies who are deemed non-productive or redundant, i.e. those that do not generate enough wealth, are disproportionately vulnerable and are allowed to prematurely die. In addition, Tyner argues that increasingly, necrocapitalist logics rely on some bodies being more vulnerable to premature deaths over others. The best way to fully grasp these concepts is to consider the contradictions between government discourses acknowledging that COVID has led to an immense public health crisis, with essential workers leading the fight against COVID, and economic reports showing that despite or even because of this public health crisis, corporations are showing record growths. Consider, for example, the case of Loblaws. In the beginning of the pandemic, it gave its staff members a $2 per hour pandemic raise. This extra $2 in pandemic pay has since been stopped. Is Loblaws losing money? Can it not afford to keep paying its workers an extra $2? On the contrary, news reports have shown that the company has amassed profits high enough to, quote, hike the company's dividends to shareholders, end quote. Juxtaposing these two realities, that essential workers are no longer receiving pandemic pay as we proceed into a new resurgence of the pandemic, and as we witness even more outbreaks in grocery stores, while shareholders enjoy more money, highlights the precise workings of necrocapitalism. Consider also the case of for-profit long-term care homes. I've already mentioned that between 82% and 90% of all COVID deaths in Canada are tied to long-term care homes, with personal support workers and healthcare aides working in these facilities being the most likely out of care professionals to get COVID. Private long-term care homes have the worst health outcomes during COVID. In fact, in recent weeks, in the wake of reports of even more outbreaks in long-term care homes, there have been more calls from advocates and from opposition party leaders, such as New Democratic Party leader Jagmeet Singh, to abolish private care homes. Workers in these homes who we interviewed have also called for better labor conditions and also for a permanent pay increase. The extra $4 in pandemic pay that they received in the beginning of the pandemic has since been lowered to an extra $3 in pandemic pay, but only until March. They say that this extra money doesn't adequately compensate them for their increased workload. Are there more outbreaks and decreased pandemic pay for workers because for-profit long-term care homes are having a hard time coping with the pandemic? If that is the case, why then are we seeing private for-profit care corporations enjoying improvements in their market performance? Reading about how most of the COVID deaths in Canada are tied to long-term care homes and talking to these workers in these homes about their experiences of substandard working conditions, while also seeing these companies growing and shareholders profiting, again shows necrocapitalism at work. And we are all complicit in allowing necrocapitalism to continue. All of us are enmeshed in this system where our idea of what is acceptable keeps shifting, influenced by the false dichotomy being presented to us, health or economics. Whereas in the beginning of the pandemic, we all likely agreed that no one should die of COVID, now, somehow, we've gotten used to the new normal. Instead of aiming for zero COVID deaths, we have somehow changed our thinking to agree, without questioning, that we shouldn't aim for zero deaths, but an acceptable number of deaths. We are okay with COVID deaths, provided we don't have to think too much about which communities are dying. In internalizing these ideas, we have forgotten that the imperative to keep the market growing has caused racialized, working class, migrant communities to be disproportionately affected by COVID. Necrocapitalism dictates that where you are positioned in the class and race hierarchy determines your vulnerability to premature death. As human beings, we will all die, of course, but our social positioning as seen through the types of works that we do and our exposure to risk and to premature death determines when we die. In short, we need to resist the idea that we've all internalized that COVID deaths are an unfortunate but inevitable reality of living in a pandemic. Exposure to COVID in workplaces like long-term care homes and farms and schools could have been avoided, but necro-capitalist logics mandate that these lives should be sacrificed in order to keep the economy going. And to repeat, the lives that are worth sacrificing are those of seniors. See, for example, Texas Lieutenant Governor Dan Patrick's statements that grandparents should, quote, sacrifice themselves to the economy, end quote. The lives that are also worth risking are those of women and racialized working class migrants. What then with necropolitics of states' determination of who may live and who must die? Is Canada complicit in necropolitics? You might be shaking your heads at me right now, thinking, Ethel, we are a multicultural oasis with a liberal immigration policy. We have universal health care. We have a feminist prime minister. We all know that companies are evil, so everything you just argued about necrocapitalism is sad but unsurprising. Can we really call the liberal multicultural state that is Canada complicit in necropolitics? Allow me now to turn to immigration policy and care work, my primary research and advocacy interest. I want to discuss the sharp contradictions in policies towards different migrant groups to illustrate my point that Canada, on the one hand, sees migrant workers as providing valuable work that is crucial to Canadian society, while also, on the other hand, deeming them an economic and security threat. My point is this: Canada welcomes immigrants, seeing them as essential to the economic and social growth of the nation, but in times of crises, such as a recession or a pandemic, the same migrants who Canada welcomes are constructed as being both necessary and a threat. Undergirding these contradictions is an abiding ethos of necropolitics. These contradictions become even more obvious during COVID. Let's talk about 5 groups of migrants. First, let's consider the experiences of internationally trained doctors. Many of you in the audience know the difficulties of getting foreign degree credentials assessed, especially for internationally trained doctors. The official reasoning behind presenting roadblocks to getting internationally trained doctors accredited to practice in Canada is that Canada simply cannot guarantee the quality of the medical training doctors from abroad have received. It is, the logic goes, essential to the safety of Canadians to make internationally trained doctors fulfill requirements first. Yet, what happened with some provinces during COVID? Because of the need for doctors, the province of Ontario, for example, is issuing supervised short-term duration certificates, allowing internationally trained doctors to work under the supervision of a Canadian trained doctor. A few internationally trained doctors have applied for these certificates, valid only for 30 days, in the hopes that their decision to put themselves on the front lines during the pandemic will be looked upon favorably when they are applying for Canadian citizenship and or when they are applying for their medical licenses. The decisions to give internationally trained doctors temporary medical certificates lays bare the fiction that Canada is trying to protect the safety of Canadians by having these doctors pass, during normal times, numerous requirements before being able to practice. Why during COVID do we say we need their skills now and allow them not to go through all of the qualifications that they have to get, but when there isn't a pandemic, we say that they present a threat to Canadian public health? Could it be that the policies themselves were only designed to gatekeep? Second, let's talk about migrant farm workers. Many agribusinesses rely on migrant farm workers entering through programs like the Low-Skill Temporary Foreign Workers Program and the Seasonal Agricultural Workers Program. On March 16, Prime Minister Justin Trudeau shut down the borders, but 2 days later, just 2 days later, after being lobbied by agribusinesses who reminded him that we still need to keep feeding Canadians during the pandemic, Canada amended its border closure policy to allow for the entry of migrant farm workers. As part of their conditions for entry, migrant farm workers would have to quarantine for 14 days before they could work. And some workers, specifically those coming from Jamaica, were made to sign a waiver where they agreed not to blame the Jamaican government for any costs, damages, and loss from COVID. During COVID, working conditions in farms are abysmal. There have been many COVID outbreaks in farms. Workers who have tested positive and who dare speak out, such as Luis Gabriel Flores, have been fired. In order to keep food supply chains going, the Ontario provincial government ruled in June that asymptomatic workers with COVID can keep working. Today, in response to calls from workers and from advocates for more protections, the Ontario government further announced that it would ramp up calls for more voluntary cleaning and sanitation. These responses, according to workers and advocates, are woefully inadequate. Why not institute mandatory and random workplace inspections, they ask. Third, let us turn to temporary foreign workers who were part of industries where there are COVID outbreaks. Specifically, I am thinking about meat packing plants like Cargill, whose workforces consist of low-skilled temporary foreign workers. If you will remember, in Alberta, Cargill had to shut down briefly because of a COVID outbreak among its mostly Filipino workforce. The Alberta government, through spokespersons like Dr. Dina Hinshaw, said that Filipino culture is to blame for COVID. She claimed that Filipino work ethic that mandates going to work even when sick spread COVID, conveniently forgetting that managers threaten workers with reprisal if they miss too many shifts. In blaming Filipino culture, structural workplace conditions are ignored. Hinshaw also blamed Filipinos for spreading COVID because of our purported cultural preference for living in large households. In doing so, Hinshaw ignores systemic racism and classism. As my co-writers Whitney Hayes, Marco Luciano, Dina Neri, and Micah Panhaitan and I show in our report, Precarious Workers, Precarious Housing, Filipino and other racialized migrant workers have a hard time accessing housing because of endemic racism against Filipinos by landlords and by the perception that some migrant workers present security risks. The government of Alberta, by the way, allowed Cargill to reopen after 2 weeks, despite the opposition of its workers. While Cargill workers initially receive a pay rise during the pandemic, from my understanding, this pay rise has since been rescinded. Fourth, I now want to talk about international students. Contrary to popular perceptions that international students are all rich and are here only to study, a collaborative research study I conducted with co-investigators Jessen Reyes and Matthias Guerra from the Migrant Resource Center Canada shows that international students have, in many ways, become Canada's new temporary foreign workers. Over the past decade, the numbers of international students who are older and who are coming here with degrees from their home countries have risen. This means that many international students are entering the country on international student visas in order to get a foothold into Canadian permanent residency. Since the pandemic, many international students have faced economic anxieties, magnified by restrictions on their visa limiting their ability to work to 20 hours per week. My co-investigator, Dr. John Paul Katungao, will talk a little bit more about her study in the panel following this keynote. The Canadian government recently lifted restrictions that say that international students can only work up to 20 hours per week, allowing international students to work more than that, provided that they are working in essential industries such as meat packing plants and long-term care homes. With respect to the latter, personal workers who we've interviewed and whose narratives I will come to in a second have told me that they are being made to train international student visa holders to do personal support work because some long-term care homes are seeing international students as an untapped source of labor. And finally, let's talk about migrant care workers. I am currently part of a collaborative research study with Gabriela Ontario and Migrant Resource Center Canada, examining the experiences of Filipino migrant care workers during COVID. I, along with co-investigators Dr. Jessica Tikar and Matthias Guerra, photo voice consultant Maurian Tolentino, collaborators Dr. Marissa Largo, Dr. Connolly De Leon, Caitlin De Rosari, and research assistants Bea Sirdan, Micah Panhaitan, and Micah Jaimalin have been conducting talk story, kwentuhan, sessions via Zoom with different live-in caregivers, personal support workers, healthcare aides, and other care workers. While our project is ongoing, one thing is clear after conversations with 31 Filipina care workers. Migrant care workers have to navigate being seen as both providing essential work and as being seen as a threat to public safety. In the beginning of the pandemic, much of media coverage actually blamed migrant care workers for spreading COVID. Media blamed care workers because they keep working in different facilities. Thus, according to some reporters, they keep bringing COVID to long-term care homes. Some of this reporting also said care workers were to blame because they don't know how to wear PPEs. Well, such hysteria has died down a little bit, with provincial governments recognizing the important work care workers provide by giving some, but not all care workers pandemic pay. It is illuminating to hear from care workers who discuss the effects of contradictory policies and rhetoric on them. To be clear, the pandemic has affected migrant care workers differently. Those who already have Canadian citizenship and who work in unionized environments face more security compared to those who only have temporary work permits and who are non-status and who work in non-unionized work environments. Yet despite these key differences, which I can go over during the Q&A if people like, the similarities of workplace precariousness is sobering. I've already spoken about how pandemic pay is insufficient. As one personal support worker told us, a pandemic pay of an extra $4 an hour, which has since been lowered to $3 an hour, doesn't really compensate for the extra work that they have to do. Tinataya namin ang buhay namin araw-araw, says another PSW. Every day we put our lives at risk. Is $3 really worth it? The most revealing example of how migrant care workers and their everyday work are socially constructed as providing necessary labor, but are also seen as threats, however, can be seen through their narratives. As some migrant care workers have shared with us, why is it that there are signs saying, "We support care workers, thank you care workers, you're all heroes," on the one hand, yet on the other hand, such gratitude has not translated into fair compensation, into extended health benefits, and for some, the provision of Canadian citizenship? Why is it that some care workers' employers openly acknowledge that they wouldn't be able to function without care workers' help, yet the same employers explicitly prohibit them from using their washrooms or from using their kitchens to eat? This is especially ironic since the intimate care work that personal support workers and caregivers perform involve the mundane but important tasks of helping people bathe, shower, get dressed, brush teeth, and eat. There is a level of intimate trust involved in care work. Yet despite the intimacy that is already at the core of this relationship, some employers still see the bodies of racialized migrant women as constituting such a huge health and safety risk that they bar these women from using their washroom and even from sitting in their kitchens to eat. The lack of access to public space, in fact, is a huge problem for community personal support workers whose workday involves going to different clients' houses. Since indoor dining, at least in Toronto, is closed, as are libraries and other public spaces, caregivers do not have access to places where they can use the washroom and eat between client visits. In pre-pandemic times, care workers will quickly go to the library or to Tim Hortons to eat and to use the facilities. Now they don't have anywhere to go. We can also witness these contradictions when looking at immigration policy towards care workers. There have been many attempts to amend the caregiver program, but in its current iteration, to qualify for Canadian citizenship, migrant care workers have to finish a 2-year work contract, will have to show their completion of 1 year of post-secondary studies, and will have to pass an English or French language test showing their intermediate comprehension of the language. We could have a debate about the legitimacy of these requirements, But what strikes me as being really appalling when thinking about how many caregivers are finding it challenging to fulfill this criteria is that once again, the Canadian government is giving contradictory messages. On the one hand, Canada claims to accept and value the contributions of care workers. Yet on the other hand, Canada seeks to limit the possible economic threats that care workers might pose by asking them to meet educational and language criteria that would supposedly determine their success in the Canadian labor market. What these educational requirements and language tests suggest is that care work, which is seemingly deemed essential, cannot by itself be considered a contribution to Canadian society. I know that I may be harping on a technicality here, but let me explain it in simpler terms. Care workers, by virtue of them being currently employed as care workers, already show that they are contributing to Canadian society. They don't need to pass an intermediate language test to show that they can get by because they are already getting by. And in a time of a pandemic, the Canadian government's insistence on maintaining these requirements seems especially short-sighted given our need for more healthcare workers. What ties the experiences of internationally trained doctors, migrant farm workers, low-skilled temporary foreign workers, international students, and migrant workers working in essential industries is that they are only conditionally accepted into the Canadian state. And such conditional acceptance is deliberate. Internationally trained doctors are conditionally accepted into medical professions during COVID, but are normally presented with barriers that make it hard to practice medicine. Migrant workers are conditionally accepted into Canada only if they keep working in their jobs. In order to ensure that there is a steady supply of workers in essential industries that Canadian workers generally don't want to be part of, the Canadian government issues migrant worker visas that are tied to their employers and their occupations. What this means for all 5 groups that I talked about is that they are allowed to keep working and living in Canada, provided they show their willingness to put their lives at risk. Thus, the Canadian government embodies necropolitics. The Canadian government is clear on which lives it prioritizes. I also want to emphasize that in an environment where we are viewing everything through COVID, we forget that the requirements imposed on these groups of migrants are based on a false premise of protecting Canadians from the threat they constitute. Simply put, internationally trained doctors should be given licenses to practice, and all migrant workers should be given status now. If we want to ensure that there are workers in unpopular industries like care work or farm work or manufacturing, then we should improve conditions of work and give better pay. Let us not tie migrants to these workplaces. I would like to briefly note that there are workers who are contesting these policies. In fact, part of our work on the Filipina Care Workers and COVID-19 project involved talking to community activists to discuss social movement organizing during COVID. Many reject the false notion that it is a choice between economics or health. They hold policymakers individually accountable for the policies that they make that compromise racialized migrant communities. Many of the activists we spoke to, in fact, noted that this pandemic, when seen in conjunction with Black Lives Matter and Indigenous activist calls to defund the police and abolish the carceral state, have inspired new and older generations of activists. They point to how this current moment has shown that all of our struggles are interconnected, that the logics of necro-capitalism and necropolitics, of white supremacy, of neoliberalism, have shown so starkly that if we don't act in solidarity, there will be more premature deaths, either within the criminal justice system or within the healthcare system and within workplaces. We are starting to realize the truth of the notion of shared fate. Trying to put care rather than profit in the center of my life is something that I've been trying to do. Change starts within the community and within oneself. Other than my ongoing research and activism, which has ramped up because I can see and feel so clearly how COVID has affected my family and my community, I've been trying to get rid of how I've been socialized into thinking that work determines my worth. I've been trying to appreciate being with family and with community. I'm trying to put care at the center of my life, and I invite all of you to do the same. Thank you very much.
Thank you so much, Dr. Tungohan, for that incredible and amazing presentation. And thanks to all our viewers for the comments and questions. We should move forward to the Q&A chat now. So just a moment as we get that set up. So I'd just like to remind people to navigate to the next module on Teachable to join the live Q&A. We also posted a link to it in the YouTube chat and then also on Teachable. So make sure to click that link and the password, and there is a password, so it should be secure, and I believe it's just relocation. So please join us at that link to begin the live Q&A. Sorry, just a clarification. The password is relocation without an S. So we'll just wait as people trickle in, and then we'll begin in a few minutes.